Good morning, it's Dr. Murphy with Murphy Medical Associates, our team at coronatestct.com. You are watching Murphy's Medical Minute. Today is February 18th, 2021, and we are going to be talking about vaccines today. We're going to spend some time talking about vaccines. We are live streaming on Periscope and on YouTube. We're going to get our questions from our Periscope viewers today. You're going to get our Periscope viewers today. A lot of you have found me on Periscope because we showed off our new cool toys, right? It's like Joker saying, where does he get all the cool toys? Well, we showed off our Swoop, right? Our hyperfine portable MRI machine in the office. We're very excited about these machines, but I'm not going to talk about that today. Today I'm going to talk about vaccines. Vaccines. Which vaccine do you take? Who should you take? How should you do it? We're going to go through a little bit of that today. So you have to have some comments or questions. Feel free to hit me up on Periscope. Feel free to hit me up on Periscope. But if you're watching on YouTube today, you can also do it through the chats and those sorts of things. So just keep me in the loop. Anyways, without further ado, you're watching Murphy's Medical Minute. Today's February 18th, 2021. Sit back, have a cup of coffee with a Papa Bear, and enjoy. Guys, the snow is coming down. I don't know if you guys know, but the snow is coming down here in Connecticut. It is significant snow here in Connecticut. So I want to let you guys know at our sites. We today have closed our Greenwich site. We've closed our West Haven site. We are in our New Haven site, our Stamford site, and our Stratford site today. We also are doing home visits. We're running around all over the county doing home swabs as we prepare for vaccination. So I want to give you a little update on what Murphy Medical Associates is doing for vaccines. We have been approved by the Citywide Immunization Registry and the New York City Department of Health. We will be distributing vaccines in our Battery Park office in New York City, and we're going to do home visits in underserved areas. I'll let you guys know that a big thing for us are taking care of those who need it most, those who are most neglected. And we found exactly that in Connecticut. Under 10% of vaccines have been going to people of color, and that's just mind-blowing. Really can't happen. And so we're desperately trying to shift that. We're pivoting that. And what we're finding is, even though we set up vaccination sites in areas where underrepresented minorities are living, the vaccines are still going. They are still going to people of means. It's remarkable. And many other states, we're seeing travel, right? Pennsylvania's sending out and allowing vaccination of travelers. I happen to know that because I'm from Pennsylvania. But if you have to weave your way through the site, it's kind of crazy. Another thing that's going on is not every state is adhering to the same roll-in protocol, so it's very confusing. It's very confusing. Add in the difficulty of the winter in the Northeast, and you add in the confusion of the variants, and there you have it. Not everyone who's eligible for vaccination is getting vaccinated. Full third of people, well, maybe a little less now, in the United States don't even want to take vaccines at all. And they are very confused about it. So we're going to go over a little bit of that today. First, I want to talk to you briefly about the update. I'm going to give you a little update on how we are looking in the state, how we're looking in the state of Connecticut with vaccines. So without further ado and without further craziness, we'll go over a little bit of that. We're going to go over a little bit of that. So here is the weekly provider update. So a weekly provider update. Oh, let's get that set up for you guys. All right. So there's lots to celebrate, right? The state of Connecticut is doing probably one of the best jobs in the country in vaccination. And that's no surprise. Our team at coronatestct.com also led the way in the nation with crushing the numbers. Why did we crush the numbers? Because we tested. Test, treat, isolate, trace. Now, I think we did a great job with that. And holy cow, look at all of these things that I have up here that I got to shrink so you guys can see this a little bit better. So you can see this a little bit better, right? We'll shrink all of this stuff so we can focus on the stuff that matters, right? So there's lots to celebrate. Lots to celebrate in the state. Lots to celebrate in the state. On the 12th of February, just 6 days ago, so roughly like a week ago, right? We had 27, almost 28,000 vaccines administered. For a small state, that's a big deal. 65% of those 75 plus have received their first vaccine. So COVID kills the elderly. There is a significant proportion of elderly in the state of Connecticut. Significant proportion, very similar to Florida. We have managed to vaccinate 65% of individuals who are at highest risk of dying from COVID. That's great. The Pfizer vaccine and the Moderna vaccine are the distributed vaccines right now. We know both of those vaccines. What's up, Linda? Welcome aboard. We know that both of those vaccines do a great job at preventing death and severe disease. Hospitalizations reduced. They do a great job with it. Great job with it. We don't know whether those vaccines will prevent transmission or not. We're learning about that. We're studying it. The data is getting reviewed. There are a lot of people figuring it out. We know that there are around, maybe 690,000 vaccines that have been distributed in the state. So almost 700,000 vaccines distributed and administered in the state. Of those, 218,000 people in the state have received their second dose of the mRNA vaccines. Now remember, the mRNA vaccines are vaccines that cause our cells to make a new protein. Doesn't mean that we have genetic alteration in our body to make this protein. That's not how it works. We've basically hacked our cellular biology to create a protein that we traditionally don't create. And because we don't create it, our antigen presenting cells notice it, our immune system picks it up, and we make antibodies. And that's what vaccination is about. Also, we know that vaccination helps with T cell response. So we're working on that too. We're going to talk a little bit next about the updates on allocation. We believe that the Jnj vaccine is going to get into the state of Connecticut in March. When people ask me, when do you think you'll get the Jnj vaccine? Remember, this is a vaccine that doesn't require the deep freeze. When will you get the Jnj vaccine? The state's going to have it in March. Do I think our private practice will get it? Well, we still haven't gotten the other vaccines. Our freezers are empty. Well, guess what? I'm glad now our freezers are empty because our temperature monitoring service, Linda asked a great question, but I'm gonna answer this first. Our temperature monitoring service is in Texas. Texas. Okay, so that's a problem. That's a problem because they couldn't monitor due to power outages. They couldn't monitor due to power outages. These power outages are going to affect the distribution of vaccines in many states. Luckily, in the Northeast, we know a little bit about power outages. And so our freezers are hooked up to generators, right? So we've got a battery generator that can help keep us in the deep freeze if there's power outage. Essential for these vaccines. When we look at the vaccine distribution where we're at, by March 8th, we should see around a significant incremental volume of Jnj vaccine. Second week in March. And this is going to be essential because the Jnj vaccine has South African variant protection. It has South African variant protection. And that is very, very, very important. We'll go over that in a little bit. One of the things that I wanted to tell you and I want to get over is the fact that those who are underserved, those who need vaccination and care the most, those who were disproportionately affected with death and disease from this virus are not the ones who are getting vaccinated. So Linda is already talking about a third dose. She's talking about a third dose of vaccine with the Pfizer and the Moderna vaccine. The answer is yes. There's no doubt you're going to get that. You're going to need that third vaccine. But the problem I have here, put simply, is we are not getting vaccine into those who need it most for their first dose, let alone their third dose. And so we currently are seeing places, Mayor Elliker in New Haven's doing a great job with Director Bond, setting up sites in underserved communities and getting outreach to be able to vaccinate those who need it most. But in these winter storms, who's going to sites? Not a lot of people. And that's why I think we need to start doing at-home visits. We need to start doing at-home vaccination. It's not as efficient as a mass vaccination center, but you truly are going to be able to take care of those who need it the most. And at Murphy Medical Associates, it's one of the things we're set up to do. We have our vans ready to do home visits. We have our nurses ready. We have our nurse practitioners ready. We've got our doctors ready to go out in the field. We have been testing, and one of the big things we've been testing back when we were really in the heyday of testing here with this, we were testing in homeless communities and testing on the New Haven Green, which I believe was essential to take care of our homeless population. Dr. Dalal and the team at the Department of Health continue to do that outreach, and I think it's very essential. Very essential. We need this in all of our communities. New York City, I know Representative Levine is doing a great job. I'm glad, Linda, that you're going to get your second dose on Friday the 26th. That's very good. Very good. Take 2 doses. I don't know what's going on here with people trying to short hop 2 doses of Pfizer vaccine. You need 2 doses. Done. End of story. There should be no more debate about it. No more debate about it. We should ramp up production of vaccines and not have to short hop these. That's just crazy. All right. So lastly, the Department of Public Health says Jnj Vaccine, it's coming soon. Yeah, it is. And I think at Murphy Medical Associates, we're probably going to have it mid to late March. I'm certain. Mid to late March. And that's when we're going to be vaccinating. We'll expand the population. One of my good friends and a patient just told me that the rules they're Byzantine rules. They literally are Byzantine rules. So right now, we are vaccinating healthcare personnel. We're vaccinating those who are 65 plus. We are not vaccinating those with pre-existing conditions that put them at high risk. Hypertension, obesity, asthma. These are things that lead to a higher risk of death with COVID. Why aren't we vaccinating those people? Lots of other states are doing it, and so that's a real question that I have. It's a real question that I have. I believe that we need to scale up our vaccination programs. The federal government's going to do a good job in helping us with this. Thank you very much, President Biden. We really need to scale this up. We need to get a better effort. States are great for these sorts of things, but we need a national coordinated effort. National coordinated effort. So that's my update from the state. It's my update from the state. Now I want to talk briefly to you. About a couple of different things. The first of those things that I get a lot of questions about is which vaccine is right for me? Which vaccine is going to cover the variants? So I want to go over a little bit with you about the variants. I also want to talk a little bit about the genomic surveillance. One of the issues we're really having here is being able to effectively, I hate taking it off of you, right? Is being to effectively protect against the variants. And Linda made a great point. Right? Linda made a great point here, and it's important that we go over that. How are we going to protect against the variants? How are we going to protect against the variants? Well, not every vaccine works against the variants. And what the heck are the variants? I think in a previous live stream, I talked about the variants. And one of the most important things that we see is that there are lots of mutations. Mutations are changes in the proteins by changing the nucleic acid. Now, what you need to understand is one of the most important proteins on the novel coronavirus is the spike protein. Spike protein. It's the fist. I don't know if you can see it here, the kind of changes conformation, but it's the fist that reaches out. It reaches out. It grabs the cell, the ACE2 receptor of that cell. It pulls itself into the cell. And it says, hi, you're infected. It's time to make spike protein. Time to make all the building blocks to make more virus. And the infected cell complies. The infected cell complies. That's what an infection is. Unfortunately, then you make spike protein, you make all of the virus, which can make you really sick. And so naturally, if we have changes in the spike protein, you have to worry about changes in function. Maybe it can make people more infected. Maybe it can make people more infectious. Maybe it can make people sicker. Or maybe it can't. We really know, as a general rule, most mutations don't do anything. Most mutations don't do anything. Some mutations make the virus what we call less fit. These are mutations that make the virus less able to act. There's lots of variants out there. Most of them we don't have to worry about. But some of them we do have to worry about. And one of the best ways we can really understand what's going on is by looking at genome surveillance. The novel coronavirus, COVID-19 is the trademark name, but that's not the real name. That's like Lunesta or Viagra, right? So to a provider, that is not the best name for this virus, right? This is a coronavirus, a beta coronavirus, a SARS CoV2 coronavirus. This virus causes whole body disease. When we have mutations in it, when we have mutations in the RNA in the genome, we need to identify that. One of the best ways to identify it, see that right above me? See that right above me? That is the United States percentage. That's the United States percentage of genome surveillance. We find that states like Maine and Washington are doing the best, and that's because they have the best genome sequencing equipment, right? Maine has Jackson Laboratories, right? Jackson Laboratories that are a killer. But what about other states that are high technology states? States like Massachusetts, states like Connecticut. We're maybe sequencing 0.3% of all samples, 0.3%, whereas Maine is checking 2%. Washington is checking 2%. Wyoming is checking 2%. Now remember, these are smaller amounts of samples, right? Smaller amounts of samples, especially the Wyoming samples. There's not a ton of them. So it's easier to sequence, far easier to sequence. Now, a viewer asked me what a mutation is. A mutation is a change in genetic sequence. The genetic material that is used by the SARS CoV2 virus is called RNA, ribonucleic acid. A 3 set of ribonucleic acids codes for something we call an amino acid. Amino acids are the building blocks of a protein. Now remember, when I talked about a protein really is what is so important to get any function, right? Think about muscles, right? So muscles are proteins. There are lots of enzymes in our body that are proteins. Proteins are key to get stuff done. And the virus needs proteins to replicate because the virus is not alive. Let's remember that. What is dead can never live and can never die. Just like Theon Greyjoy. What is dead can never die. Therefore, when everyone talks about getting rid of the virus and just eliminating it from life, that's not a reality, guys. It's not a reality. So the variants that matter, right? The variants that matter. Well, let's talk about them. Let's take a look at the variants that matter, right? Over here, you'll see the variants. You see the variants, right? When we look at the top variant, that's called the variant isolated in the UK, B117. B117. It's the variant isolated in the UK. We know that it's more infectious. New data shows that it actually, the infection increase is due to a longer time to recover. You carry the virus longer. Our body's having a harder time clearing the virus. New studies show that. What does that mean? That means that that virus theoretically also could make you more sick. And guess what? New data shows that it is. New data shows that it is. Sorry about all the text. Even on airplane mode, everyone can text me still. And that's important because I'm a doctor and I'm on call. So I get my pages. Where was I? Yes. The UK variant can make you more sick. We know that. We have data that shows that now. The good news, Pfizer and Moderna, I don't know. So as I'm talking, someone just asked me, how do those viewing your Periscope see the stats you're referencing for your YouTube viewers? I don't know. I don't know. If someone can teach me how to pop up these stats on Periscope, it'd be really cool. Or I could hold like a board, right? I mean, some people, news accounts, they hold the whiteboard up and write on the whiteboard. I don't know. That's not me. I guess I could print them out, hold them up to you. I hold them up. Maybe we'll do that. I got to figure it out. But Periscope's going away anyways. So tune into YouTube. You can have both of them kind of running and rocking at the same time. There's a little delay on YouTube, but you can always try that. The next variant that I want to talk about is the B1351. Someone called it the other day the 1351 variant. And you know what amazes me about all of that stuff? And I'll tell you. I'll tell you right now. Okay, we got problems. All right, I'm getting texts about patients that have COVID that have some abnormal symptoms. So the question we had is the following. Just popped up on Periscope. Which vaccines protect against which variants? We know the following with pretty good data. The Pfizer and Moderna vaccines that are available currently protect fairly effectively against the United Kingdom variant. Fairly effectively. Unfortunately, because we're not doing enough genome surveillance in the United States data is lacking. The United States data is lacking. And remember, Murphy's rules about science. CTFO. Don't go too crazy, especially with data that's not peer-reviewed, and with data that's not independent. What does that mean? I'll tell you right now. Put simply, if Pfizer puts out data, I'm skeptical if it's data about their vaccine or a competitor. If Moderna puts out data, I'm skeptical because, again, they have self-interest. Mark Twain said there are three types of lies. Lies, damn lies, and statistics. You can manipulate data. Which requires us to read studies effectively to truly understand what's going on. So with the vaccine data, the most important data to me is independent data from independent sources. Even not governmental data, but funded data by government probably is one of the top levels. Probably the top level. plus a little self-funded data as long as it's not from the manufacturers. That data is probably top level as long as it's peer-reviewed. As long as it's peer-reviewed and published, it's a little bit better. That takes longer to come out, guys. That takes longer to come out. So we have to understand that. We have to understand the limitations with that in terms of coming out. It just takes time. So the B1351 variant. All right, this variant has been shown to escape AstraZeneca. We now know much more data on this. The AstraZeneca vaccine is essentially a failure. It's a failure against the South African variant. The Novavax vaccine is far less efficacious against the South African variant. The Jnj vaccine is not 100% effective against the South African variant either. But the biggest failure here was the AstraZeneca data. The other day I presented to you non-peer-reviewed data about the South African variant evading the Pfizer vaccine. The reason I presented that to you is it was independent data. Independent data, meaning it was not funded by Pfizer, it's not funded by Moderna. It was independent data, and that independent data showed that we had escape from the South African variant with the Pfizer vaccine. So there we go. We've got the South African variant evading vaccination. The South African variant evading vaccination. Come in, Ave. So it's escaping vaccination. And that's very real for the South African variant. It's very real. The most important part about it is the following. We have the South African variant in the United States. It's here. There is no doubt about its location in the United States. Let's take a look. So the South African variant has been found in the United States. It's been found in Texas. It's been found in California. It's been found in South Carolina. You take a look. Right about there. Boop, boop. Right, take a look. So it's in the United States. The South African variant is in the United States. One of the other important things about the South African variant is that we don't know a lot about it. We don't have enough data like we did in the very beginning with the UK variant. So the South African variant, B1351, not B1351. It's like someone who doesn't understand how to read chromosomes. The bands of the chromosome, the P arm versus the Q arm. It's the same thing. It's a rookie move by a professional journalist. B1351. B1351. The variant isolated in South Africa. Remember when we heard about this UK variant and we didn't really understand. We didn't quite understand, is it more infective, is it not? We try and take the scientific theory first, right, which says null hypothesis. Mutation is not associated with outcome. The null hypothesis says association is not causation, number one, and there is no relation. This is why we have to study to prove or disprove relation. The same is true here with the South African variant. And we also take a cynical view of other people's reports. But guess what? Britain was absolutely correct. Bojo said the following: the variant is more infectious. The variant is more deadly. Even if just infectiousness increased, you'd have more people die. But we also found out, based on the studies, guess what? It's also more deadly. We need to pay attention to what is coming out of South Africa and what the South African government is saying about the South African isolated variant. They're saying the following: don't use the AstraZeneca vaccine. They're asking for the J&J vaccine because the J&J vaccine was studied in an area of endemic South African variant. Here's what they found. You want to see what they found? No hospitalizations or deaths. No hospitalizations or deaths. 100% protection. That'll adjust as we get more people vaccinated with the J&J vaccine. The sooner we get more people vaccinated, the better. I think you're right, Linda. The public can be a little distrustful of that, though, and they are worried that we're rushing out vaccines that do not have full FDA authorization. And so, we have to find a way to relax everyone's fears. There are real fears there. I mean, there are real fears there. Real fears. Why? Well, take a look at what I just showed you. Right here we are. Take a look at what I just showed you. Remember, Luce? Autoimmune disease from vaccination happens. We see it. Whether it's from the influenza vaccine, with ascending paralysis called Guillain-Barré, or whether it's from things like autoimmune thrombocytopenia. Autoimmune thrombocytopenia that attacks our platelets. These things are real. They're not fake, they're real. And so we have to acknowledge them, we have to recognize the risk, and we have to present that to patients. We have to present that risk to patients. If we don't, or we hide it under the pillows, it's not going to work. It's not going to work. And about 1 in 3 Americans say they don't want to get that vaccine. It's a week ago, the poll was published. 1/3 of Americans, 33%, do not want vaccination. They don't want vaccination at all. So how can we get them over the finish line? How can we get them over the finish line? And I think one of the most important ways is to offer different vaccines. One of the best vaccines I think here is the J&J vaccine. I think the J&J vaccine, we can demonstrably show that vaccine protects from death and hospitalization from the South African variant. It protects from the UK variant. The Novavax vaccine, also no hospitalizations or deaths in the South African variants. We know the AstraZeneca vaccine is probably not going to work at all against the South African variants. So how do we fix that? How do we fix that? Well, which vaccine is right for me? Which vaccine is right for me? And it depends on where you are. It depends on where you are. And one of the reasons it depends on where you are is because it depends whether we're screening. It depends whether we're screening or not. Are we effectively doing genomic surveillance? Are we doing genomic surveillance? Does it work? Yeah, it works. We need to do more of it. And so that's why I was heartened when the federal government said they're going to put $200 million into genomic surveillance. $200 million. That's like how much the insurance companies should be paying a day for testing. 200 million. 2 million tests. It's probably 300 million these insurance companies should be paying for testing in a day. But we're not doing that many tests, and that's a problem. That's a problem. So how are we going to fix that? How are we going to fix that entire thing? How are we going to overcome? The way that we overcome is through a hearty genomic surveillance program. Dr. Grubau's lab at Yale came up with a quick, down and dirty, great surveillance tool for our positives. We were able to find the first UK variants in Westchester and in Fairfield County. How were we able to do that? Well, we were able to do that because we had a robust genomic surveillance. Robust genomic surveillance. All of our patients at Murphy Medical Associates get sent up for genomic sequencing. All positives. All positives get checked for the variants. Why aren't other labs doing this? Because it costs money. It costs money. So the $200 million hopefully will enhance this set, right? Hopefully it'll enhance what we need to do here, right? And I can't I can't get over how important this is. So, when you ask yourself the following, which vaccine is right for you? Which vaccine is right for you? I'm here to tell you right now that you should take whatever vaccine you can get. And be prepared that if you have a Pfizer or Moderna vaccine, which is what we have in Connecticut right now and in the United States, you're probably going to need a third dose. You're probably going to need a third dose. The J&J team believes that you're probably going to need a vaccine every year. They believe you're probably going to need a vaccine every year. And at the rate that this virus is mutating, maybe he's correct. Maybe the CEO is correct. Put simply because we have variants all over the place. And if we don't test, we can't do the rest. I've said that from the very beginning. Test, treat, isolate, trace. If we can't test, we can't do the rest. I think that we need to invest far more money in being able to obtain samples that can be screened for their genomes. We need to be able to test for COVID, and we need to be able to test, obviously, for other viruses too. But this year's taught us a lot. Taught us a lot. And one of the most important things it taught us is the following. We can crush RSV and influenza by wearing masks and socially distancing. But we can't crush COVID that way. All right, this is Dr. Murphy, Murphy Medical Associates, and our team at coronatestct.com. I love you guys on Periscope. Oh, kid wants to get my charger. Can you believe that? The kid wants to get my charger.
I have 0% though.
Okay, well, hold on. I'm going to finish up with my crew. You want to say hi? You want to say hi? You going to come in? All right, we'll see if she'll come in or not. That's if she can come in.
Hello.
Hello, right here. Say hi to everyone.
Hi.
Hi, everyone. How are you doing? You good? You good? You're hiding on me. You're hiding on me because you want my charger.
Yeah.
What are we going to do? It's time for a brain break.
Please.
For you guys, it's time for a brain break too. It's Dr. Murphy, Murphy Medical Associates, and my team at coronatestct.com. You've watched Murphy's Medical Minute, and for my Disney peeps, stand clear of the closing doors, please.